I'm here.
Hello.
Hello.
Can you hear me?
Yes.
Okay, cool. I had my speakers muted. How's everybody doing?
Doing good.
I am recovering.
Yeah, what's going on, Sheila? You okay?
I have Meniere's disease, and every now and then I have bouts of
Meniere's?
vertigo.
Yeah.
And I woke up, I don't know, probably about 1 a.m. Monday morning, and I mean, well, I had never had one this severe. I threw up with it and everything. I mean, I don't even remember. I remember being in the floor and being in my bedroom floor. And the next thing I remember is Timmy had me in the living room, but he said he took me through the other bedroom to try to get me in there. And I've just been so sick. And I'm still not fully recovered, but I'm a lot better today than I was. I mean, it's just been awful.
I know all about Meniere's disease. I've had a lot of problems with my ears over the years, even since I was little. I've never experienced the vertigo, but I have a lot of other symptoms.
Yeah, the ringing and all of that in your ears, and
I've got permanent ringing in my ears forever.
Me too.
Yeah.
Me too.
It's
And
hard.
I was telling my husband, with all of this dizziness that I've had, it has been exact. I mean, just the sound of that ringing has been even more so. And this has really been the worst episode I think I've had in probably 2 or 3 years with the vertigo. But it has been really a major ordeal. And I slept sitting completely straight up.
Oh wow! Yeah.
I mean, I have had last night. I was able, because I always have to sleep with my head up somewhat, or I get dizzy. I can't lay flat, and haven't for years. But I literally sat just like I am right now, with pillows up against my head, and I was on the couch. Well, I was in the floor for a long time, and I just sat with the pillows up, and I was up against our recliner because I couldn't even stand anything to move in front of me. My cat went by, and I threw up.
Oh gosh.
Because the motion sickness was just so severe. But
I'm sorry, that's awful.
Yeah. Yeah. I hope it's a long time before I go through something like that again.
I know you've had a lot of diet changes over the years, but I found that my ringing is less with low salt, low sugar.
Salt.
Yeah. And I really take a weak coffee now. Like I take, like if I do have coffee, I really weak.
Yeah.
And it
Do
just kind
you do decaf at all, or
of,
just
I
with
was
coffee?
for a while, and then I just had that cup of coffee again, and I don't know, I guess I got hooked again. But yeah,
Mhm.
what I'll do, like a normal cup or a normal pot of coffee, or a normal, depending on what you're making, like a French press, you can make up to 60 grams, which is 2 tablespoons,
Uh-huh.
rounds. So what I do is I just do 30 grams, and so I'll just cut it in half, and then it's not
Yeah,
very strong. And it
right.
just kind of keeps me coasting, you know?
That helps.
Yeah.
That helps with that
But
ring.
yeah, like a week coffee, and it kind of keeps me concentrated and focused on other things while the coffee's hitting me, and then I don't have
Right,
to think about the ringing, and then I'll just keep moving.
right, right.
But,
Is your foot recovering well?
yeah, I got about 4 more weeks in the boot, but I can stand on it a little bit and put about 25% pressure now. And that
Oh,
was
that's good.
as of yesterday. They just told me I had an appointment yesterday. I actually
Yeah.
went to the office for like a second, so because my appointment was in the building.
Oh, okay.
Yeah, it's getting there. I'm going to start PT too. I'm going to take PT as far as I can.
Mm-hmm.
I think. I want to be 100% back on my foot. I really do. I just don't
Oh,
want to.
yeah.
I just
Yeah.
can't imagine having any more trouble after this.
Right. Yeah. You've got young kids and
Yeah,
you need that.
yeah, and they've needed me more than ever during this time too, and it's really
Sure.
hard to hand that stuff off to somebody else. It's
Oh,
really,
yeah. Yeah, that has to be hard, Kevin.
well, it is what it is. I mean, I can at least open my eyes and not feel dizzy like you. I'm so sorry.
Yeah.
That's rough. I hope that doesn't happen ever again. But you might want to look at an article. There was a UFC fighter that had Meniere's disease that went over to Germany and got stem cell.
All right. So welcome to the Appalachian Diabetes Network virtual office hours. Today, we will talk about health disparities and the impact of systemic racism in Appalachia. In today's virtual office hours will really just be a facilitated discussion about health disparities, health equity, and what that looks like in your respective communities. So we'll just talk about what that looks like in your community, if there's any programs that you're implementing to address health disparities. Are there different organizations that are addressing health disparities? Is your coalition implementing any activities or programs to address health disparities? And if you have any programs that you would like to recommend. We will also share some resources for you that you can use if you're thinking about developing specific programs for subpopulations, minorities, immigrants in your community. So a little bit, before we get started with our discussion, and I do have some discussion questions for you, I would talk a little bit about health equity and health disparities. So on the screen, you can see when we think about equality, it's really everybody has the same, I guess, box to stand on, but they may not necessarily be equal. So people have access to different resources. You can have differences in your social, economic, your geographical location, like many of our coalitions are located in rural communities. So just because everybody has access to the same resource doesn't mean it's equal for everybody. And if we look at health equity, it's everybody has the appropriate resources to achieve their optimal health. So based on whatever their circumstances are, they may need more resources or less resources, but they have what they need to achieve optimal health. Does that make sense to everybody?
Yep.
Okay, cool. Okay, and I know we've all heard this before. This is in a lot of our public health meetings. We always talk about social determinants of health and how those social determinants impact our health outcomes, our quality of life, and they also impact health disparities. So some social determinants of health which really relate to all of us, all of our coalitions in Appalachia, whether it's our economic stability, that could be income, employment. We know that a lot of our communities have lower household medians or lower, they have higher poverty rates. We know that support, especially in our coal counties, where a lot of the coal mines have closed down. There's not really a lot of economic support or industry to support the people that live there. So economic stability is a really big factor when we think about health. Next, we have neighborhoods and physical environment. In all of our evaluations, transportation is always a big issue, especially if you're thinking about how you're going to get to the doctor and you don't have a good public transportation infrastructure. So transportation is always a hot topic about how do people get to the doctor. Not having access to specialists is always a big barrier when we look at health. And also, because we're promoting the prevention of diabetes or the reduction of the diabetes prevalence rate, having access to parks, when you think about walkability. I know here in Greensboro, we only have sidewalks in like a 1 mile radius downtown. So Main Street, there's sidewalks. Outside of that, then you're on your own. You're walking in the street with the cars. And I remember, I have a short story. When I first moved here with my son 7 years ago, we moved from Texas, and all the kids walked to school. I mean, that was normal. He rode his bike to school. So when we first moved here, I was like, just ride your bike to school. It's like a half a mile. I was like, just ride your bike to school. And the principal called me and said that my son was not allowed to ride his bike to school because, number one, there were no sidewalks, and number two, they didn't have a bike rack. So I was like, okay, that's different. So he has to ride the school bus to go like a half a mile. So that was really different for us when we first moved here. And I'm sure you also have, stories about not being able to walk, which impacts your ability to exercise. So do you have a safe place a park, a safe community park to walk, access to physical activities for children, adults? So that can be a really big barrier for rural communities. Education, so we know that sometimes communities in rural areas have a lower literacy rate, a lower high school graduation rate for various factors. And then food, and this has been a really big topic since COVID. Having access to healthy options. I know in our county, we only have one grocery store now, and the prices have dramatically increased over the last 3 months. So having access to fresh fruits and vegetables, especially when you have one grocery store. So having that community infrastructure to provide, we have churches that are just disseminating food, drive-through food campaigns to help people who don't have access to food. And then social, community and social context, when you think about the social support system, so you have food pantries, you have community events. We used to have an event here called Movement on Main Street, and we had that a couple of years when we had different businesses come down. We had Cub Scouts, we had our Boys and Girls Club. They would use that as a fundraising opportunity. It was kind of like a big fair downtown where we promoted the businesses, and people just came out and enjoyed the food, and they bought they bought from the vendors and the stores. So is there a sense of community within your county or your city? Then we also have some cases of discrimination and how that impacts the stress level of your community. So is there discrimination? Is there discrimination and people don't talk about it? Is there like blatant discrimination? When I first moved to Alabama, there was some certain experiences that I had that weren't so pleasant. So, you know, people have different experiences based on where they are in their community. So we'll talk a little bit more about that when we get into our discussion. And then healthcare. So healthcare coverage, if you have Blue Cross Blue Shield, Aetna, if you have multiple insurance providers, Medicaid, Medicare, like I said, we have one hospital in our county. I'm glad we have one hospital because there are some counties that don't have any hospital at all. Don't have that many primary care providers. So what does that look like in your ability to assess your primary care provider and taking care of your needs and your family's needs? So having the ability to better control your diabetes or prevent chronic pain management, especially if you don't have transportation to go to a bigger city, that impacts your ability to control your condition or better manage it, I would say. Any questions about social determinants of health, or does anything on this slide pop out that's relevant to your community?
I think in my community, I'm seeing a lot more people that are homeless and more people that are, you know, when you think about substance use and things like that, you know, that's certainly on the increase too, which really, you know, even if there are jobs in my community, they're not sustainable jobs. They are, you know, you've got a family of 4 and you're working at McDonald's, you know, and or you have to drive, you know, so far away. You have to drive to go to Charleston to get a decent job, and then you don't have the transportation, the reliable transportation to go to work every day, which is, you know, over 50 miles one way. And so we're seeing more and more, you know, of the substance use and things like that on the increase. And then, you know, housing is also a lack in my community too. There's just not that available housing that's for folks either. So
in our county, we don't have a hospital anymore. It was shut down in 2014. So, you know, having been used to having a hospital right in Brown County, that's been a big adjustment, particularly for the emergency medical services who, you know, really are slammed because they've got to go to either Adams County or Highland County or Maysville, Kentucky, or over into Claremont County instead of a short run into Georgetown. So that's, I think that's really had an impact on access to certain kinds of care. As far as the food goes, I think in both of our counties, and Sharon, chime in on this if you would with Adams, but we've got 2 communities in Brown County now, 2 larger towns that actually have grocery stores. And all the other grocery stores have closed down in the past probably 5 to 7 years, I guess. And I think a number of them have closed down in Adams County as well. Have they not, Sharon? If she's still here.
I'm here.
Okay.
Can you hear me?
Mm-hmm.
Yes. One major store closed down, but there was a Walmart in that same town, that same village. So still yet, there are areas that, you know, they're like food deserts. There are areas that we really people don't have access to food.
Sad.
Couple of things I noted, transportation. This is in reference to healthcare. People didn't have transportation initially during the virus when trying to get to Starkville, which is where they go for cancer treatment. So that was an issue, especially, take for instance me, if you wanted me to carry you, I was a little leery because of the pandemic. Our parks are closed because of COVID also. So again, you don't have access to a physical environment, and I didn't know that until this week. Food is an issue as well. So there are several organizations that are giving out food through some of our churches. So that's been encouraging. Our hospital we have one hospital that has 14 beds. Our hospital was destroyed in the 2014 tornado. We don't have an ICU unit. So we have to go 30 miles to Starkville. Sheila, you're familiar with our area, or to Tupelo, which is maybe an hour and a half drive, Meridian 60 miles. So that poses a sort of a dilemma for us here in our county.
Thanks, Janice. Dan, did you have anything to add?
Well, my county has a lack of access to the playground equipment and to the parks and all that, but it also has a very, very small hospital without ICU and that sort of thing, and it's far away from everything. But we only have 2 grocery stores. One has very limited amount of stuff, produce, that sort of thing is just really limited. So I feel a lot of the same things you guys are feeling. We don't have it. It's not very friendly for a lot of socioeconomic reasons.
Right.
Absolutely, absolutely. We could see that most of our counties share similar traits as far as social determinants of health, whether that's economic, education, food, health systems. So I wanted to share this resource for you from the from Health Disparities in Appalachia. This is a website that the Appalachian Regional Commission developed. It's interactive. You can put in your county, and there are 41 different measures that you can pull up. Like if you wanted to look at food deserts in Macon County, Alabama, you could do that, and then you could drill down to specific neighborhoods in your county. So this is a good resource if you wanted to pull any data specifically about health disparities based on social determinants of health for your state or your county. So that's just a resource.
Yeah, that's probably one of the best ones that I have come across. And in 2018, during our coalition conference, Eric Stockton presented on this too, and had just rolled it out. So
yes, and we do have several of our coalitions that are featured as bright spots. Bright spots are meaning counties that are doing better than expected compared to other communities around the country. So I would highly recommend checking out the bright spots. We have, I think there are at least 5.
yeah, one off the top of my head is Noxubee, Mississippi. They're a bright spot.
And then Hale County, Alabama was one of them also.
Yes, yes.
Okay, so now for our discussion questions. So the first question would be, what do health disparities look like in your community? What do health disparities look like in your community? don't all talk at once. I'll go first. So here in Greensboro, Alabama, when I think about health disparities, I think about the impact that economics has on access to healthcare, quality healthcare. And I really see that with our public housing communities where people have lower incomes, they don't have access to transportation. So there's a big divide between people who have higher incomes or who are not in poverty in their ability to access healthcare services. Even knowing like where to go to get certain services, because people don't know if they don't know, but people aren't necessarily sharing information with everybody. So there's a big stigma against the people living in public housing in this county.
I think we have a geographical divide and a socioeconomic divide. The impoverished, the poverty levels are high. Even the median income, I think, is still for this area is lower than Tennessee's. Everything it's impoverished. But Bledsoe County has a valley that is the main part of town. But then there's 3 or 4 mountain ranges around in every direction, and it's cut off from everything. So I think the geographical divide, and then transportation. People that live on those mountains, that's the higher rates of poverty, and they can't get even to the valley to town, which town is very tiny, but everything's in town. Everything that they need is in town or another town, which is even worse, harder to get to. So I think people living remotely and having lack of transportation and lack of resources and lack of education, everything, it's so spread out that it's hard to get it to everybody.
Okay, so the next question is, what are the key initiatives or programs that are working to address those health disparities in your respective communities? Are there any?
Our churches and our food banks are huge. Without those, people would be hungry.
So talk a little bit more about that, Jen. So our faith organizations or churches, they're disseminating food to people who live in those remote, isolated areas?
Yeah, our food banks are mainly in town, but we have some churches that have church buses, church vans that will pick up and take to some of the more remote areas. I think on one of our field trips, you guys went with us to Luminary. And in Luminary, there's a fire station and a church way back in there that a church van takes things from downtown Pikeville, our big city, up to Luminary. And that's a good drive. It's a 30-minute drive at least. And there's Brockdale, which is just as impoverished. There's all these areas on different mountains in different directions that are pockets of poverty without transportation and without resources. So we've started putting information, healthy recipes and that sort of thing inside the food bags. So that we're trying to educate while we feed them, because there's just not enough resources. There's not enough of us to get it to all these areas. And they don't all have internet, and they don't all have, and they're not trusting, so they're not going to listen to a lot of things we say. But if it's in print and if we back it up and do it well enough, maybe it'll help. I hope.
I do remember the Luminary. I do remember.
Yes. And we didn't go to the end of it because the people I were with were chickens. I think it was Michelle driving, or maybe Susie. Somebody was a chicken.
Let's talk a little bit about that. This safety concern. Is it a real safety concern, or just the perception that Luminary isn't safe, and why is that?
police won't go in there after dark. There's places back there. It's well known that because people live in campers and they live in, there's one area that has cardboard boxes, and I don't know how in the world with as much rain as we've had they are, you know, making it right now. But they live, there's a like a little camp area of people that live in cardboard box that have cardboard housing. And so they found that a lot of those people are, they move to that area. Even there's a website showing that you can move to that area. I haven't seen it lately, but there was a website showing if you are running from, if you need to be police free, you go to that area.
So maybe people living off the grid there, or there's the perception that people who live there may have broken the law in the past, or maybe criminals. So that's definitely, you know, a health disparity, because that may or may not be true. So that kind of groups everybody in one category based on what people's perceptions are.
Right. And there's a lot of signs saying beware, stay out, you know, things about guns and stuff out there, but it's not everybody. And so you don't know who, you know, wants their privacy that much that they would be willing to be dangerous, or who wants, you know, help. You can't help from one house to the next.
Yeah, and it's difficult to form a relationship with folks that live that far out. And, you know, unless you go unless that's your purpose, you know, to visit one family, work with that family and work with that family, and that family knows somebody else, and, you know, pull that family in and really just start with one family or one home. But I know we have some areas that are like that here in my neck of the woods too. And, you know, because and some of them are from out of state. It's not just, you know, people that are home. It's like people, in all honesty, a lot of people move from other areas because I have heard, and I'm not saying, but some of the churches that I'm affiliated with will have communicated with these people, and they come because we have more churches in our area that will feed them. And they're, you know, they come from cities and, you know, places like that, and you know, and they're fearful. Some of them don't have. It's not necessary that they don't have driver's license. They don't have IDs. They're nomads.
I think a lot of ours don't have ID because they have multiple names. They just don't want to be known. And I don't know if it's, you know, a mental illness or a criminal background. Or
a lot of mental health issues and you know, and things like that are associated with that. And it's really sad, you know, because sometimes you feel like you're at a loss and you can't reach those people like you want to, but you want to.
One way I found to get to the folks, at least in Luminary, and I'm about to do it for Brockdale too. There's a little tiny grocery store, and the owner of this little tiny grocery store is extremely well known in that area, and he's trusted. So you can leave things at the grocery store, information, and like we had an STD outbreak, and so we left free condoms, just boxes of them. Anybody that wants them, please use them. And then we put some information on, you know, on the side of the box about, you know, about why they should be using those besides birth control.
Right.
There's one little tiny outlet, but there's a little tiny grocery store, even smaller, on Brockdale. So we're going to try that too.
Sure. Okay.
Right. So really we talked about trust. We know that in small communities like ours, building trust is really, it's a long time. You have to develop relationships. If people don't know you, they're less likely to participate in your programs. But if you're from the community, if you've built rapport, you're more likely to have participation in programs. Is that true for everybody?
Yes.
Okay. Let me check the chat box.
Tammy Pennington says true.
Yes. Okay, so let's talk a little bit about what the current challenges are to addressing those health disparities in your community. And Jen, you talked about this a little bit about the transportation, the safety concerns, other people's perceptions about the people or stigmas about the people who live in those communities are impacting the ability to provide them with the necessary services that they need. Are there any other challenges that are impacting?
The one Janice said. It's what Janice said. It's about the current is COVID, where no one, even if they had a friend that could take them.
Absolutely, you're absolutely right. So it's the fear over the pandemic. We have people who have underlying conditions, and they may be at risk for developing, you know, other conditions or severe response to COVID. So especially since we have higher rates of diabetes, higher rates of hypertension, cancer. So people are a little leery about going out and trusting people, especially if they have to be in close contact with you. I know in some of our counties and some of our states, people aren't taking the necessary precautions. They don't have like a state mandated mask requirement. So it's really left up to the county or the city to implement those different strategies. And some, like our younger people, may be asymptomatic, but they have older adults in their household, and they're just not wearing the mask, especially since they've gone back to school. We're seeing a spike, uptick in the rates for younger people.
This is probably true in every county, but one thing that has really come to light through the produce prescription program that we've done in Adams County. This is our second year. Is I've had many of the same participants. Unfortunately, we can only have 10 because of the funding. But one gal who has been in the program for 2 years now, there are multiple generations of her family living in her household, you know, and she, who is the elder of all of these, the matriarch, is the one responsible for finding resources to feed all of these people that live in her home. She can't afford fresh fruits and vegetables without this produce prescription program, without the free vouchers that we're subsidizing through the Creating Healthy Communities program in Adams County. So that's only 6 months out of the year. She said, you know, I need help all year long. I have so many people that live with me. And one of the challenges for us is being able to find funding to continue programs that probably are effective and will help these people with diabetes to at least manage their diet better. You know, it's just seems like it's just short-term interventions, because resources are needed by everyone, and they're just so few and far between that being able to continue and sustain programming like this is really difficult.
Right.
I think that's one of the similarities we all share. There's a small pool of funding, and we have a large geographic area, and we're all going out the same funding.
Yeah.
And yeah, I think that's one thing that we all share. And instead of pooling our resources together to say, how about we all partner and go together and go after this funding? There may be a sense of competition. There are certain people who don't want to work with other people for various reasons. And I know that's certainly the case in this county. So if we're able to pool our resources and maybe jointly apply for funding, we can make the funding last longer and share the resources. But in some counties, there is that sense of competition, especially when there's a finite amount of money, which brings me to the point of the census. The census workers are always out there. You know, census is the way that we determine which communities get funding. So in our communities, we don't have a lot of people to start with. So counting all the people in our county, even those like in Luminary, the ones that don't want to be counted, impacts the number of federal state dollars that we get for programs that we want to implement. So having people, you know, participate in the census and get counted, so we make sure that we are getting our fair share of federal and state dollars is very important.
So how are you getting them to do it?
I'm not getting them to do it. I just did my own.
They're probably.
Well, and then you go again, you know, take what Jan just described. You've got a lot of people that don't even have an ID or anything. And, you know, you've got these people in the remote areas. These are the people in the poorest of poor counties that we're wanting to serve. And yet, how do you go and do a census with people that, you know, obviously don't want to be counted because they don't even want to communicate with you?
Absolutely.
And so we have a challenge, you know, that's why that's why working under the ARC umbrella, as we have for all these many years, is we work in the poorest of poor counties. Yes, there's over 200 and some or 400 and some, you know, counties or more, you know, that we're looking at in a region. But the poorest of the poor is really, that's where you guys are at. That's where we're hearing we need sustainable funding. And our counties, you all do such a good job at really partnering with other people in your communities, the organizations. And I think that's the beauty of all of it. And y'all make your money go, you know, you stretch the dollar as long as you can possibly stretch this funding and add to it as you can. And, you know, not even counting all the in-kind contributions that you guys do on your own, you know, for your counties. And, you know, and that's why we're constantly, you know, trying to find sustainable funding for our project. And I've always advocated, you know, why fund more counties whenever we just really need to just focus on the counties that we're at right now and really help them maintain sustainability in the programs that they're doing.
Regina,
Yeah.
we're talking about health disparities. So with the pandemic, think about people that already have issues, whatever they might be. I was talking to some ladies yesterday. You having to put your health issues on hold now because of the pandemic. So what's going to happen, you're going to become sicker because you can't get into your appointments. You can't have surgery. You're just going to become sicker. So that's a disparity to me. And I just thought of that. So you're just going to be, you know.
Absolutely, especially if you have a pharmacy and your pharmacy has limited hours now, they may close earlier. Having your ability to get your medications in a timely manner will impact your ability to, you know, self-manage your condition. So you're absolutely right.
So they're dealing with that. And also thought about communication in our communities. You have the older populations, they don't text, they don't do Zoom meetings, word of mouth, just the telephone. So they're at a disadvantage now as well. So we're just dealing with those challenges in addition to people, if the factories closed down, the plants, whatever you want to call them, you don't have insurance anymore. So you're running into that in addition to what you had before. People can't afford it. What are your priorities with what you get? Our government is like to have a head in the sand. So we're seeing things we didn't see before, or we chose not to. What do you choose to do with your money? Mississippi unemployment is 235. What can you pay with that? When I was teaching school, I often went to the board and did minimum wage. You know, we need living wages, not working wages. So how can you live on that?
You're absolutely right. And I know that's been a big political discussion. We're not going to get into politics, but you know, people who are unemployed in the rural communities and not having enough money just to make ends meet, not even thinking about the prescriptions they may need to get, but basic necessities like housing, food, shelter, clothing, like meeting those things first before, you know, everything else. I mean, you're absolutely right.
Yeah.
When you look at the health disparities that already existed, and then you look at things like, I almost hesitate to bring this up, but we don't know, you know, the post office mess. How does that impact people? You know, we know a lot of veterans get their meds that way. A lot of other people, I'm sure, relied on the mail for their medications and other things that are important. So, you know, it just seems like it's a domino effect sometimes. And I'm not necessarily saying the post office problems are because of COVID, you know, but when you look at some of the disadvantages that we're, you know, all at, and obviously some a lot more than the, you know, some of the others of us, because of the pandemic, and then you layer that on top, it just, you know, seems to make it even worse.
And then Tammy put a comment in the chat box. Her mic isn't working, but along the lines of politics, would politics be a disparity? Because in her area, people don't even believe that COVID exists because of their political views, and therefore
Right.
they're not practicing social distancing. They're not wearing a mask. They're,
Right.
you know, they may be contributing towards the spread of it because they think it doesn't exist. I mean, and you're absolutely right.
They won't get tested because they're of their political views sometimes.
Yes.
If you can get tested, if you have the ability to get tested, you know.
Available in your area. You're absolutely right. And then what role can our coalitions take on? And these are some problems that have existed. When you think about health disparities and the root cause, I mean, there's not anything that we can do to really address the root cause, but what we can do is we can put some strategies in place to kind of address what we can. So tackle what we can and do the best we can with what we have. So it's impossible to address, you know, economic issues where we have poverty and we have people who don't have access to, you know, certain resources, but what can we address at the coalition level to help reduce some of the disparities that exist in our community? So instead of focus on what we can't do, because we can't solve, you know, world poverty or world hunger, but what can we do, the small role that we can make it better for that one family or those two families or a neighborhood, what can we do at the coalition level?
Well, this morning, I'll just share, this morning I sent out an email to our coalition members and asked them to forward that information on. My husband is military, so I'm signed up to get military emails, and it was about healthy planning, meal planning, exercise, all of that. Also, at our home mission meeting last night, there's an elder lady in our church. So we're encouraged to continue with our lunch on us. As we cook a meal, save a meal for her and just drop it off to her house. She's about 92 years old. We can continue when we know there's been produce boxes being given. We can send out texts to people that we know to encourage them to go by the drive-through and pick up a box, not only for you, but for additional members, you know, in the community that are elderly and don't have transportation, so they will get some as well. And also our coalition has 2 programs coming up. One has to do with Tennis Fit for Life. That's, I'm not sure how many weeks, and we have a walk away, a 10 weeks program that starts September the 3rd. So those are things that we continue to do.
Okay.
I think some of our coalition partners have, you know, been addressing some of these disparities through, you know, different avenues. For instance, well, we have our federally qualified health center organization that's a member now, and they do some things to try to improve access to care. And even, I know in Georgetown, after our access to care, since we no longer have a community hospital there. And we do have a number of our primary care providers in our area who are getting to the point where they're old enough and they're retiring. And it's harder to find, you know, a new primary care provider because we only have so many. But like APCAP, which is our 2-county community action partner program, they do a lot of different things, whether it's providing, you know, certain kinds of healthcare services or helping people to try to find employment. You know, they run the WIC program, they run the Head Start and the Early Head Start programs. They've had a Farmers to Family program going on all summer where, you know, with the extra food that the farmers had that they couldn't move because of the pandemic, they're shipping stuff down from farms up around Cleveland on the opposite ends of the state. And they come down in big refrigerator trucks on a weekly basis. And then APCAP is kind of, you know, they've developed a network of volunteers with different organizations. And every Wednesday morning, and they've had to move it to the fairgrounds down the street a bit from APCAP because parking was terrible and traffic was awful. But basically, they tell people to come with an empty trunk and an empty back seat, and they have all kinds of fresh fruit and vegetables and dairy products and all kinds of fresh food that they, you know, there's no eligibility requirements. I don't even think there's residential requirements for that particular program, but they're hoping to continue it. But, you know, that's just one kind of example of addressing the food issue. And we've also tried to work with some of our local food pantries, you know, and Marshall's helped us with some of our funding in the past, and then we've passed that along to some of these organizations to help improve their, you know, make them choice pantries and those kinds of things. So I think the networking of members in our coalition, and because we have different member organizations in our coalition, we see a lot of efforts towards disparities. And, you know, Debbie even mentioned, who mentioned the prescription produce program.
Mm-hmm.
You know, that's one example of that too.
All right.
Every little bit helps.
It does. Every little bit helps. The more information we can get out to our community members about programs that we know of helps reduce those disparities. It helps increase access to fresh fruits and vegetables. It helps people, you know, get to their doctor or get where they need to go. And so I think that's one of the valuable resources that we can do as coalition members is just share what we know is going on.
Right, and that's what we try to do too. Any member organizations that are doing these big programs, we're trying to get the word spread through our membership, through our, you know, we're beefing up our Facebook page, you know, in this virtual communication era right now with the pandemic and so on. So we're trying to do what we can to get the word out to more people.
know we talked about this before in the previous office hours, but are there any programs that you had to modify that you were offering in person that you were able to continue virtually since the pandemic, or did you just lose a lot of programs because they were predominantly in person and you couldn't do them virtually?
We did our produce prescription program in person last year, and everyone had to convene at the physician's office for a monthly nutrition education program that our SNAP educator at the extension office provided. And then if they came to that, they got their vouchers for the next month. Well, we weren't able to do that this year, and we weren't really able to do it virtually because so many of the participants don't have a computer, don't have internet, don't have a phone that they have Facebook on or whatever. So we've had to solely just mail them their vouchers with nutrition information inside it. So, you know, I'm glad they're getting the vouchers, but that one-on-one, even if it could have been virtually, to try to be able to answer questions. We shared recipes. We brought in food for whatever recipe we were talking about for the nutrition education, and we've lost that with this mailing system. So we, you know, even being able to use Zoom or any kind of Facebook Live or whatever doesn't work in a lot of our areas, you know, unfortunately. So mailing was the only option we had to be able to continue the program, but it's working. They're getting their vouchers and they're using them. So.
And I've had the same problem. I facilitate a DPP program, and when we had to stop the in-person classes, I lost half of my participants, and then we transitioned to Zoom. However, just like you said, if people don't have, you know, a smartphone or a way to get on there to actually communicate, it doesn't work. Unfortunately, with Zoom, you can call in, even if you don't have like a camera or video. We also use freeconferencecall.com, just a regular telephone line where people were able to call in and participate, but it's really not the same, especially if you're working with older adults and they're used to seeing you face to face. It's that personal connection that we lost. And then I still had to mail people their modules. And some people didn't get them. And so it created like a sense of confusion. So what now I'm thinking, if I'm going to do this class again, what will it look like in the fall? Like, how can I make it better, knowing that we're still probably going to have the pandemic around, we don't have an approved vaccine. So how can I improve that particular program as the pandemic, goes on?
Well, interestingly enough, our local area agency on aging did the diabetes self-management program out of Stanford. They actually did it via phone during the summer.
Did they take the special training that Stanford was requiring if you were to deliver CDSMP?
I can't say that for certain, but I'm assuming they probably did, because they have been doing this. They've been doing this program, and interestingly enough, and Debbie, correct me if I'm wrong, they basically said they maintained, I think, 9 people in the program the whole 6 to 8 weeks, and they actually had more participation from more people verbally by phone than they ever saw with in-person groups. Which I thought was pretty interesting. But sometimes people are hesitant to speak up in a group, you know? And so I thought that was interesting. That kind of, to me, was a positive twist on having to do something, you know, differently. That's the way I looked at it anyway.
And that is a different way of looking at it. It just depends on your population and if your population is used to doing things, over the phone or virtually, like younger people, they feel very comfortable with social media, so they're not good communicators in person. So it just depends on your demographics of the population that you're targeting. But that's something to consider. Okay, and then
Will we get a copy of this?
Yes, actually this is going to be posted on our YouTube page, and we can send out actual PowerPoint after.
That'd be good.
Thank you.
You put your, let me see. Sheila, can you write down everybody who's on? So I
I've
can.
already done that.
Okay.
We can put them in chat.
You already got it.
Yeah.
Okay.
Thank you.
So some resources that I've listed here, and these are readily available online. But there's a program called REACH. It's the Racial and Ethnic Approaches to Health, and it's developed by the CDC. And it really has some good tools in it about how to reduce racial and ethnic disparities based on different ethnic groups. So there's different resources for African Americans. They have social media templates on there. They have print materials on there for specific populations. So if you have, immigrants or specific subpopulations in your community, this is a great resource you can use for health tailored content for that particular population. And I've used some of these resources in my DPP class before, because my class targets African Americans. And then the Health Equity Toolkit, that is a great resource. And I think that's also by the CDC. The Practitioner's Guide for Advancing Health Equity is really tailored towards healthcare providers, and talks about how to use, what words to use, the language when you're talking to people, not to place stigmas, like certain, the appropriate language to use, and different cultural differences different ethnic groups have. So that is a great guide to use. And then Promoting Health Equity, a resource guide to help communities address social determinants of health. That's a PDF. And there's some great resources in there that your coalition can use if you're thinking about tailoring messages to certain ethnic groups. And then this is the site I use a lot for my class. There's lots of resources available from the Office of Minority Health based on different ethnic groups. You can click on each link and it'll tell you about, diabetes prevalence rates or hypertension rates, cancer rates. And they also have different brochures and messages that you can use for those different ethnic groups. And then this is a new resource I found. The University of Virginia, they have a video series on special priority populations. If you're teaching the National Diabetes Prevention Program, or you have a coalition member that's teaching the National Diabetes Prevention Program, they have a set of videos that you can watch on how to engage certain ethnic groups. So how do you engage Latino communities, or how do you engage African American communities and target them to participate in the National Diabetes Prevention Program. So I thought this was a really neat tool for communities who are wondering, how we don't have any Hispanics participating in our programs, we don't have any African Americans participating. How do you engage those specific ethnic groups? Which is, the first one talks about building rapport and trust, and we talked a little bit about that when we first started, especially in rural communities when you have multiple layers of subsets. So we already live in a rural community, and then you put, ethnic differences on top of that, and then racial differences. So it's like an onion. You got to peel it back, and it takes time to get down to what relates to people. So building trust at multiple levels takes time. I lived in Alabama 7 years, and it took me the whole 7 years. So it takes time for people to get to know you. They want to know your family. So it really takes time to build trust with community, especially if you're planning on doing programs with them. And then the University of Virginia also has some additional resources, and this will be in the link. There's videos, PowerPoint presentations that you can go back and share, the webinars you can go back and share with your coalition members.
Regina, I was typing and trying to get this stuff sent out to folks. Did you mention that UVA will be having a training for anyone who is trained through NDPP to do it virtually? They'll have they'll be doing that. I believe they'll have information in their newsletter next month about that. There is a charge for that though. It is not free.
How much? Big charge?
I'm thinking it's close to $200 is my guess. But we will share that information with you. But if you're already trained as a lifestyle coach in the NDPP and you want to learn how to be trained to do this virtually, to deliver it virtually, you can take the training through them, and they'll have more information in their newsletter coming out in September.
Is it on their website?
Is it on their website yet? Yeah. I'm not sure. I know we get their newsletter.
I am DPP trained. Does that mean I'm NDPP trained?
If you're a lifestyle coach, National Diabetes Prevention Program, yes.
Okay, I just had never put the N in front of it.
Yes.
I just DPP. Okay, thank you.
The CDC would really probably slap you on your paws if you didn't say national.
It probably would.
They did that to us. And Tammy had a question. Could we use grant funding for virtual training? Sure. Yeah, Tammy, are you talking about the funding that you got from Marshall? Yes. Yes, I think that would be appropriate. What do you think, Sheila?
Yes, absolutely. Yes. Yes. So if it's funding that you receive from us that you want to take this training, yes, use it. So that
even if we're already deep, even if we already are the other, it's okay.
If you are the other.
NDPP, if we are already in DPP, but we're not virtually in DPP.
Well,
right?
Yes, if you are a lifestyle coach and you want to take the training that UVA has to do this program virtually and pay for that out of the funds that we have, absolutely, you can use our funding to do that with.
Very sweet.
Yeah.
It's essentially the same program. They're just teaching you how to better facilitate it in a virtual environment. So how can you better engage your participants? If you're looking at a video, what additional resources you can add? Because, you know, when you're in person, you can do like cooking demonstrations, you can do physical activity, but it's very different in a virtual environment. So what would that look like, and what tools you can use to implement that program virtually or via distance learning? So they just give you tips and tools on how to facilitate the same class, the same modules, the 12-month program virtually.
That would probably give some benefit for other virtual trainings too. I mean, there should be some overflow, and that should help not just in DPP, but try to help in other things. Should be better virtual facilitator.
Mm-hmm.
I did a short webinar they had, and they talked about lighting and making sure that you have a speaker where people can hear you and talking up and doing the same round robin method. So we could see like do a roll call at the beginning and make sure you're having everybody participate. So call on somebody if they're, you know, quiet. So it's using the same techniques as you would in person, but just using that technology to make sure everybody's participating. I enjoyed it. Okay, and then we're already past time. Another resource that we're sharing from a coalition is the Lake Cumberland District Health Department will be offering a free healthy living diabetes class, and they're doing this virtually or via distance learning, and they have a 1-800 number that people can call to register, so you don't have to be in Kentucky, you can be anywhere. So they're promoting their class. If you have a program that you would like to promote, just send me a flyer. We can post it on our Facebook page. We can share it with our coalition members. So if you think about virtual or distance learning classes, you're not really confined to your town or your county anymore. Anybody can participate. So the hope is you can increase your participation rates because you're not, you know, limited to people who live in your particular county. So we are helping them promote their upcoming class in September. And then this is a reminder that we are here to help you. We can offer Jena Yoga refresher for leaders, and Sheila has been, are you gonna do that virtually? We're exploring that.
I will be. I'm still trying to figure out how I can do this virtually and train folks. But I do look for that to be sometime this fall where I can train new leaders in gentle yoga.
So if you're interested, just shoot Sheila
And
an email.
determining whether or not I can split that up into 2 days, because you have to have time to practice teach, and that's really the hardest part, just trying to figure out how I can do this and watch folks, even though I know I can do it Zoom, just having them practice teaching and things like that. But probably this fall we'll be able to offer leader training in gentle yoga. So
that will be coming soon.
Yeah.
Having access to your coalition data reports. If you have any funding opportunities that become available, we can provide you with the data from your reports, whether it's, you know, the annual report, or if you didn't get a copy of your quarterly report or the last biannual report, we can provide that to you. Basic Zoom training. Once again, if your coalition needs one-on-one or specialized basic Zoom training, we can do that. Newsletter assistance, we can help you with that, and then promoting your Facebook or your social media accounts, we can absolutely help with that. We've recently have started using YouTube, so that's been interesting. So, you know, having the ability to create videos and then post them in a location where people can go back and watch them over and over, and you can see how many people watched it, people can make comments. So using technology, it has a learning curve, but it can be beneficial because you can always point people to YouTube and say, hey, go look at our YouTube channel, we got videos up there.
Hey, Sheila, back to the gentle yoga refresher. Will that be for folks who are already trained in that, or will that be for new folks? I've got someone in Adams County that would like to do that.
For new folks.
Oh, okay, good.
Yes, I can do a refresher. That's no problem. But if you have not trained, if you have not led a class in the past year, you really need to be trained again. You know,
and that's coming virtually.
And that is coming. Yes.
Okay, great. Thank you.
Mm-hmm.
All right, and then this is how to contact us. This is our team. Nell retired last Friday, and we were very sad, but we're still gonna bug her though. She's just like Marie. She didn't really go anywhere.
Yeah, they're still there.
They're still there in the background. You just don't see them as much, but they are still there. And then lastly, does anyone have any questions? No questions or comments? You're awfully quiet. Well, if you think of questions or comments or additional programs or resources that you would like to share with us that we can share with the entire network, please feel free to email them to us, share them with us so we can share them out to the group. All right, Basu, your dental appointment.
Good luck with that.
Yeah.
Dennis is not my friend. I have white coat syndrome.
My blood pressure goes up a little, but I like the feeling after. Bye, guys.
Bye. You guys have a great week.
Bye.
Bye, everyone.
Bye, thank you.
Hey, Regina, can you send me the YouTube link, please?
Yes.